So today's session is about trauma-informed care as person-centered care, and I have no disclosures to report. While I will not be showing any audio-visual depictions of trauma, if any portion of our discussion today makes you uncomfortable, just take care of yourself in the way that best suits you. You can grab a glass of water, go to the bathroom, do whatever you need to do. And our objectives today are to first define trauma and trauma-informed care, which may or may not be a new concept to you, to identify specific examples of trauma-informed communication, and demonstrate key components of a trauma-informed physical exam. So why am I here? What's my story? How did this happen? When I first started my clinical practice, I realized quickly that there were things I was doing on the physical exam that were making my patients visibly uncomfortable. I remember swinging my stethoscope off my neck and the patient jumped. I remember approaching someone for the thyroid exam and he stammered back. And so slowly I started adjusting the way that I spoke, how I stood, the way that I behaved, just in an effort to set my patients at ease. I started teaching these strategies to medical students, and one day a student asked me, Dr. Elisseou, can you tell me more about your trauma-informed techniques? And I was like, trauma, what? Did you just make that up? What are you talking about? And she said, actually, this is a very well-established framework for supporting people who've experienced all kinds of traumas, and it can be applied universally as a means of building resilience. Beautifully, trauma-informed care fosters healing through people, through safe and collaborative relationships, which means that every interaction you have with someone can be seen as an opportunity to reverse that negative impact of trauma. And I thought, oh my God, why has nobody told me about this before? This is amazing. And I couldn't unsee it. I couldn't unhear it. It explained so much. So I basically locked myself in an office for a month and read everything that I could about trauma-informed care. And I developed a formal framework for a trauma-informed physical exam, which is now being taught at medical schools across the United States as the new way of examining patients. This is a short list of medical schools that now have a standardized trauma-informed care curriculum, and that list is growing. You see that these are leaders in healthcare. These students are going to graduate in a couple years, they're going to go to residency, they're going to start practicing on your wards and your clinics, and if what they're seeing is not trauma-informed, that's going to cause some dissonance, perhaps some moral distress, perhaps some moral injury. So we're on kind of a timeline here to get this process moving. In this ripe environment in society now, where stress levels have climbed to the point of being toxic, trauma-informed care is a rapidly growing social and academic movement. Oprah's book that she released with Dr. Bruce Perry, who's a renowned traumatologist, is called What Happened to You, and it's firmly rooted in trauma-informed principles. There are entire healthcare systems that are becoming trauma-informed, and the word trauma is starting to pop up everywhere in popular media. So it's a very exciting time to be doing this work. In the pandemic, I started applying trauma-informed principles to organizational well-being and had the opportunity to teach these principles throughout Procter & Gamble for their employees, their global HR team, and their executive leaders. So it's a concept that's expanding to other corporate sectors, not just healthcare. I can tell you very clearly, patients want clinicians who are trauma-informed. I remember a patient who came in with a chief complaint of rectal bleeding. I knew, as his primary care physician, that he had a history of childhood sexual abuse. I did the best that I could for the rectal exam following a trauma-informed approach, although I was really nervous about it. And at the end, he told me, "You were very professional. I'm glad that you're my doctor." So what is trauma? Just being clear about definitions. There are many definitions. I like this one because it's clear and simple. These are the 3 E's according to SAMHSA. SAMHSA is the Substance Abuse Mental Health Services Administration. It's any event that is experienced as harmful and has lasting adverse effects. So it can be a lot of things. There are so many experiences from the individual all the way up to the societal levels that have the potential to be perceived as deeply distressing. And I know we can all think of many examples right now. We have things like discrimination, sexism, racism. We have violence and abuse like adverse childhood experiences and intimate partner violence. Transgenerational trauma like slavery and war. Natural disasters, including pandemics. Medical trauma like the stuff we see every day. Physical trauma like motor vehicle collisions, and importantly, social determinants of health. I know there's a concurrent session right now about these. So housing insecurity, food insecurity, et cetera. If you look at this list, you can see that these are very common, very human experiences. So trauma is no longer something that only our patients undergo, but we can think about our staff, our trainees, people at this conference. It's very likely that something has impacted us deeply. In terms of statistics, one national study showed that 89% of the US population will experience at least one traumatic event in their lifetime. It's like nearly everybody. And it's associated with very important acute and chronic physical and mental health conditions, including an increase in mortality. So this is very relevant to health and public health. Importantly, trauma can take away one's sense of safety, autonomy, and trust. And so that's what I hope to give back to my patient in the exam room. Help them to feel physically and psychologically safe. Help them to feel empowered and in control, and help them to retrust me or the healthcare system, et cetera. What I hope to do for you is to walk you through the 4 R's of a trauma-informed approach. This is also from SAMHSA. So any trauma-informed organization, program, or process will first realize the widespread impact of trauma. Number 2 is to recognize the signs and symptoms in its staff, families, clients, et cetera. Number 3 is to respond by putting trauma-informed measures into practice. And then 4 is to resist re-traumatization. So resisting re-traumatization is really important for the physical exam specifically. It's kind of the riskiest thing that I do as a primary care physician. If you think about it, people are, they have their bodies exposed, they're maybe wearing a flimsy drape, sitting on a cold table, being asked questions by a stranger, being poked and prodded, and wondering, what am I going to discover about my health? So it is a high-risk activity. I'd like to show you a bit of my framework for a trauma-informed physical exam. So we'll be walking through how to set the stage before the exam, how to proceed through the exam, and then how to have sensitive closure for the exam. And I want to share up front that this is simply a guide. These are simply suggestions. It's not standardized, it's not required, it's not in a checklist to follow from start to finish. Perhaps the exams that you all perform or witness are trauma-informed already, or perhaps not. I would say that most of us go into healthcare with all of the right intentions, compassion and empathy, but this isn't always inherent. In many ways, it is a learned skill. So starting before the exam, we make sure that our nonverbal skills are as they should be. And what does that mean? We hope to speak clearly and slowly, to appear engaged and calm, maintain appropriate eye contact, sit or stand at eye level with the patient. These are basic person-centered skills. Avoid sudden movements, keep hands out of pockets so it's always clear what you're about to do with those hands, and always pay attention to what the patient's nonverbal cues are. You can pause and should pause if they're visibly distressed. I'm going to show you some sample language here, and I'm going to ask my friend Tatiana to read aloud what's in the speech bubble. So we're next going to set an agenda for the exam.
I'd like to transition to the physical exam. We will be doing a pulmonary exam today, so I will be listening to the lungs.
Yeah, sometimes even name the body parts I'm going to examine. Many people come in wondering, am I going to have a rectal exam today? Is there going to be a pelvic exam today? So set the stage for what's going to happen. Next is to make it standard.
This is, I didn't know if you were picking up what this is something we do for all patients who come in with a cold.
Yeah, it's standard medical practice. Next is to identify what, if any, concerns they have before the exam.
Are there questions or concerns you have before the exam?
Yeah, you can ask them, have you had difficulty with a medical exam before? And then ask about comfort.
Is there anything I can do to make you more comfortable? If you think of something, let me know.
And then finally offer a chaperone.
Would you like anyone else to be present for the exam?
So I don't offer a medical chaperone if I'm just going to examine someone's wrist, for example, but the point is that historically, institutions have mandated the presence of a chaperone for a woman undergoing a breast, genital, or rectal exam. Now, over 90% of my patients have always been male, and they're the ones who have taught me the impact of sexual violence. So this is a call to think more broadly about this. We're going to transition now to during the exam. How do we make it trauma-informed? We want to attend to draping. Susie?
In order for me to do an accurate exam of the lungs, I'll need to listen with the stethoscope directly on the skin.
And it keeps going.
I'm going to leave the room and allow you to change. Please remove the shirt and you can keep the bra on. Here's a gown for you to wear. It opens in the back. This is a drape that you can place over your lap like a blanket. I'll be back in a few minutes. I'll knock before I come in.
So you may notice that these instructions are highly specific. I remember giving instructions to a patient before a rectal exam, and I came back into the room and he was completely naked from head to toe, sitting in the regular chair with the drape still in a tiny square over his lap. And there are many reasons why that might happen, of course. Maybe they can't hear, maybe they're a little nervous, maybe they've never done this before, but being extra clear is helpful. We want to also, I like referring to the gown as the thing that they wear and the drape as what goes over their lap. And if possible, fabric gowns may preserve dignity better than the paper ones that are constantly ripping. It's great to have the patient move their own gown or clothing when possible rather than you reaching to do so. It's theirs, not yours. They can keep clothing on body parts that are not necessarily being examined. For example, if you need to check their ankle, they can just roll up the pant leg rather than removing the pants entirely. And so those are some basic draping principles. We try to give privacy when the patient is undressing or redressing, use the curtain or door. We shouldn't assume that all patients identifying as men are comfortable bearing a full chest, so I give them a gown as an option as well. Tissues are helpful following any exam with lubrication, and I like to knock before re-entering a room. It's their room at the time, not mine, so I don't barge in, and I wait for an affirmative response before coming in. Next, we're going to introduce exam components. Susie?
I'm now going to listen to the lungs using the stethoscope.
And explain why it's being done.
This is important because we need to see if you have pneumonia, which is an infection of the lungs.
Yeah, the exam is for medical purposes. It's not being done just because or for fun or just so. Ask permission before touching body parts.
May I open the gown from the back slightly in order to get a more accurate listen to the lungs?
Permission's also helpful before moving, draping, or clothing. We try to stay within their eyesight, and I have here, I'm gonna stand at your side. You don't have to say that out loud, but I'm gonna show you some pictures of why this is helpful. So when I listen to the back of the person's lungs, it may make sense for me to stand behind them, but she can't see where I am or what I'm doing, and that can be unnerving. So I still get the same data standing at her side. The stethoscope reaches, and I'm in her peripheral vision. For generations, doctors like me have been trained to examine the thyroid gland by standing directly behind the patient with the fingers wrapped around their neck and the thumbs in the back, right? And so I see head shaking in the room. This can simulate strangulation. So why not stand at the patient's side with the fingers fully extended on the neck and tell the patient what you're about to do and why? For a pelvic exam or abdominal exam, having the patient 100% supine or flat is a subordinate position and can trigger memories of prior abuse. So you can elevate the head of the exam table maybe 20, 15 degrees. She's a little bit high in this picture, but the point is to have the patient a little elevated, and you can offer a mirror for the things they can't see. There's even a movement towards self-insertion of specula for a speculum exam, self-insertion of swabs for a non-speculum exam, self-insertion of a transvaginal ultrasound probe for that exam. So this is all very exciting. Next is respecting personal space. I'll show you again some examples. If I'm listening to the front of the chest, I don't have to be in front of the person, bumped up against her knees. I can stand at the side like I did for the lung exam. Here I'm checking the person's heart rate, but my hand is a little bit close to her groin, so instead she can have the hand extended onto her knee or resting next to her on the exam table. And when checking blood pressure, which was so confusing, I remember when I was a med student how to coordinate all of this. In the first photo, I'm really, really close to her. She's leaning to the side, holding up her own arm. We're in this unintentional embrace. But in the second photo, I'm standing outside of her personal space, and so everybody feels a little bit more room to breathe. And I try to avoid blocking the exit door. If you're going to be there for a quick second just to say something, that's fine, but the patient should feel that they have access to an exit at all times. Next is using simple clinical language.
With the mouth open, take some deep breaths in and out.
Excellent. So trauma-informed language should be easy to understand, avoid jargon, be cautious with the imagery that you're providing with the patient, always avoid sexual connotation, try to minimize the power differential that already exists between the clinician and patient, and accommodate people who speak other languages. In general, the words are going to be professional and less personalized. Some examples. I like using the word the when referring to body parts rather than your, because it feels pretty different to hear, now I want to look at your penis, versus I will now inspect the penis. The means it's an anatomic body part that I'm going to check. Just like I've examined hundreds of other such body parts, it's less personal and zoned in on their body. It's a little more detached. Instead of casual terms like butt, alternative words are available, bottom, buttocks. Instead of saying that it's a bed with sheets, which can frame the exam in an unwanted, intimate manner, it's an exam table with a drape. And instead of saying provocative tests like special tests like varus and valgus and all those other things, these are additional tests or special tests. Instead of saying that something looks normal, we want to say healthy because we want to use very inclusive terminology, especially for exams of reproductive organs. Stirrups can simulate, can resemble a restraint, and so foot rests may be better. Instead of that looks good, which is a judgment, maybe that looks healthy. And instead of I want to, I'm going to, or would it be okay if, and we don't say, I'm gonna look at you and feel you and touch this. Maybe examine, checked, inspect, evaluate. These are terms that are very common during the neurologic exam, and if you scan them, they often put the examiner in this aggressive position in contrast with the patient. Don't let me do this. But we can instead use language that gives the patient control over their own body parts and just refers to the motion itself. Keep the arms up, push forward, bear down, terms like that. I've heard this a lot, put up your arms like you're gonna fight to check strength that way, but just bend the elbows. We shout at patients to relax all the time when we can't check their reflexes successfully, but the patient should have control over their knees. Allow the knees to relax. And when we say, pretend you're at the beach, just relax, take a breath, pretend you're at home in bed, we can never really make assumptions about where, when, and how someone's past negative experience took place. So here I just say, some find it helpful to take a deep, relaxing breath. And I hear the phrase "for me" being used constantly throughout the healthcare profession when we give instructions to patients, but it can enhance that power differential that exists between us, and even sometimes be sexually suggestive and inappropriate, like hop on the bed for me, take off your shirt for me, bend over for me, swallow for me. It just gets weird, right? So instead we can just omit the phrase altogether and nothing is lost. Next, we can check in periodically and as needed.
How are you doing?
Yeah, just how you doing? Using professional touch, and so what does that mean? We can consider a firm touch on the shoulder when you're reaching behind the patient to grab an otoscope or something like that so that they still know where you are in space. And then I place a firm hand on the shoulder when I'm auscultating the back of their lungs so that they're not surprised by the sensation of touch on the back. Prior to an internal exam, you can say you're going to feel my hand on the thigh or the buttocks. and prepare the patient for different sensations, like this will feel like a vibration, this is cold. Just empower them with information about what to expect. Finally, be efficient.
That concludes the exam. I'm going to step out now and you can get dressed. I'll be back in a few minutes so that we can discuss your results and come up with a plan together. I'll knock before I come in.
Thank you. A couple more points about efficiency. You can inform them about the time it'll take. Like, this will actually only take 5 seconds. You can avoid keeping the blood pressure cuff inflated for a long time because that can resemble a restraint as well. Take breaks whenever the mouth is kept in an open, fixed position because forced oral sex is actually a very important and under-recognized reason for avoidance of routine dental care. And ask the patient to show you any genital lesion rather than you taking the time to try to find it yourself because it just takes longer and it can be misinterpreted and uncomfortable for everybody in the room. Now we've concluded during the exam. Quickly, we'll just do after the exam. We knock, knock, that's misspelled, knock, knock. You ask the patient all set before you enter the room and then express thanks. Elizabeth, can you do these? Yeah, it's just nice, patient-centered, person-centered, to thank them. They're collaborators and equal participants in this team that's in the room. Next, you discuss the results.
The lungs sound clear, which is good news. You do not need a chest x-ray and you do not have pneumonia.
Excellent. So I like to discuss results once the patient is fully dressed and seated in a comfortable chair of their choice, rather than still naked and perched on that high table, right? And then finally ask for questions. Rather than asking, do you have any questions, and expecting the patient, hoping the patient to say, no, 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 I'm fine, I pause, I look at them, turn my body to them and say, what questions do you have? That means I expect you to have questions and I welcome them at this time. So this is the framework for the trauma-informed physical exam as one potential model to experiment with, play with, towards a trauma-informed approach to your visits. And in summary, trauma is highly prevalent in the world among patients and employees. It can absolutely impact patients' experience with medical interviews and exams, and we do have a responsibility to one another to foster an environment of safety and respect, regardless of trauma history. So thank you all for your time and attention. Feel free to continue this conversation with me afterwards. You can say hi and would love to chat. You can also reach me on this website, and all my love to all of you. Thank you.